Good afternoon or good morning, depending on where you're at in our state. I'm Heather Lashinsky, Deputy Director of Delivery Systems for the Division of Medicaid and Long-Term Care. Welcome to our Heritage Health Provider webinar, which is focused today on pharmacy providers. We will begin with a Heritage Health overview by Carmen from Health and Human Services, or from our Division of Medicaid, and then each of our health plans will be giving a presentation on provider enrollment, credentialing, contracting, all good things provider related for pharmacy providers for our Heritage Health program. And then we will end the call with Q&A. So we will begin. Carmen.
Hello everyone, and thanks for joining us for our first webinar geared specifically towards pharmacy providers. My name is Carmen Bockel, and I'm the Communications Coordinator for the Division of Medicaid and Long-Term Care. We're going to be focusing on the new Heritage Health program, which is the state's new managed care integrated delivery system. We have several presenters in our lineup today. Joining us from Nebraska Total Care, we have Mike Baca, Senior Vice President, Pharmacy Networks, Philip Dovkis, Account Executive, Pharmacy. On the line from United Healthcare Community Plan of Nebraska, we have Michael Horn, Chief Medical Officer, Jim Hankovsky, Vice President of Pharmacy Services, Jean Kavanaugh, PharmD Regional Pharmacy Director, and Jasmine Crenshaw, Director, Provider Relations, Optum RX. And then from WellCare of Nebraska, we'll be hearing from Bill Davies, Vice President of State and Specialty Pharmacy Programs. Then joining me from the department, in addition to Heather Lashinsky, we also have Courtney Mason, the Administrator for Managed Care and Home and Community-Based Services, Lisa Neiman, Administrator of Health Services, Shelley Nickerson, our Pharmacy Unit Administrator, and Jenny Minchow, our Pharmacist, and they will all help facilitate our question and answer portion. The Q&A feature is live on the webinar site, so you can feel free to go ahead and submit your questions throughout these presentations, and then we'll address as many as possible while we're all on the line today. I'd just like to let everyone know that this is being recorded, and the recording will be made available on our Heritage Health webpage. So first I'll begin this morning, as Heather said, by going through a presentation to give everyone an overview of what Heritage Health is, the history of managed care in our state, and what it means for our recipients and providers going forward. Then after this brief overview, you'll be hearing from each of the health plans regarding their process. A snapshot of Medicaid in Nebraska today. We currently have approximately 230,000 enrollees at an annual cost of about $1.8 billion in actual health care expenditures.
Is there Wi-Fi? Well, I should be on Wi-Fi. And as I got to the login page, I'm in.
It sounds like the lines aren't all muted. If you're logged in as a moderator, can you mute your line, please? That would be *6. As I was saying, there are 230,000 enrollees at an annual cost of about $1.8 billion in actual health care expenditures that we're reimbursing or that we're paying our health plans for. Our total budget in the division is a little over $2 billion when you include the administrative costs. So the vast majority, as you can see, is financed for the actual health care services. And at this time, about 12% of our state's population in Nebraska is eligible for Medicaid. Currently, we have a managed care program. We've had managed care in Nebraska since 1995. What managed care is a system of healthcare delivery which the department contracts with health plans to administer healthcare benefits and services for our enrollees. Managed care has evolved over a number of years across the country as the states have learned more about how to administer the programs, the types of contracts they could enter into, the different federal authorities, and the oversight that exists to help govern the programs. In Nebraska today, we contract with 3 regional MCOs, which stands for Managed Care Organization. The MCOs are contracted for physical health services for our enrollees. Physical health services would include hospital visits, doctor's office visits, those routine medical care services. So depending on what part of the state you live in, as a Medicaid recipient, you'll choose from one of 2 regional health plans for your physical health services. One plan operates statewide, while 2 others each operate in their own regions, so everyone has a choice of 2 currently. We also have a separate managed care entity for behavioral health services that's operated statewide, and there's one contractor for managing those behavioral health services, and currently that's Magellan. So almost all recipients in Medicaid that receive behavioral health services have those services administered through Magellan. And then we also separately have a pharmacy benefits manager that we contract with to manage the pharmacy services for the entire program and all of the recipients. So depending on where you are in the program and what services you are receiving, as a Medicaid recipient in Nebraska today, you could potentially be having 3 different entities managing your healthcare services, which can actually increase to 4 when you include waiver services or in-home services that we provide. So there can be a lot of disconnect between those different systems, and one of our goals with Heritage Health that I'll talk about today is to help bring those together and create a more coordinated system. Today, about 82% of our Medicaid enrollees are enrolled in a physical health managed care plan. So that's nearly everyone. And with a few very small exceptions, more than 99% are enrolled in a behavioral health managed care plan. In a traditional fee-for-service state-administered program, the state's responsible for contracting with the healthcare providers that are delivering the services and receiving the claims from them, processing them and paying for them, but depending on the level of utilization, our level of cost can be somewhat unpredictable. With managed care, we use a capitated model in which we make a fixed monthly payment to the managed care organizations, and they are then responsible for managing that provider network and paying those claims. The monthly payments are adjusted based on the level of care that an individual needs, where they live, the relative risk to their health, and this approach creates more budget predictability for the state in that we can kind of forecast our needs based on what our enrollment trends and predict how much we are going to be paying each month to the health plans for those services. Those fixed rates are developed by our actuaries. They look at our trend of healthcare costs, they look nationally at what trends are coming in terms of healthcare expenditures, and they develop rates that are designed to be inclusive of the cost of healthcare services. The managed care program also improves efficiency over the fee-for-service system in that health plans tend to be better equipped to manage the utilization. They can do care coordination and help lower overall costs by reducing some of the more costly care like emergency room utilization and hospitalization. So to compare those 2 models, we have the AtRisk model, which the payment, as I said, is made to the health plan before the services are delivered, and the risk is then assumed by the managed care organization. Whereas with fee-for-service, the state is paying for those services after the costs have already been incurred. What the fee-for-service system doesn't necessarily do is reward managing better health and having better health outcomes, because oftentimes a state of health is actually a lack of health care, meaning that you're well, you're getting preventative services, and you're not utilizing health care services. So we're trying to shift the model away from that pay-for-volume and go more toward a pay-for-value. The first steps towards this goal were made throughout the past 20 years of managed care, but you'll see that with Heritage Health, we're trying to go a step further by engaging our providers into that equation as well. So one of the key responsibilities of the plans that we've contracted with for Heritage Health is care management, really putting an emphasis on primary care, preventative care, triage, and referral out for services like behavioral health and disease management. So identifying through health risk assessments those individuals that have multiple or even a single chronic condition and stratifying them in terms of the level of risk and then plugging them into a different care management program that might have different levels of intervention. From very basic telephonic checks just to say, how are you doing? Do you need help scheduling an appointment? Do you need help with transportation services? To the more intensive care management, where they have an assigned care manager in the community that might be going out to their home and visiting them and checking up with them at different levels. So we want to see different risk stratification, different levels of care management. Quality management is really having a more formal structure, a formal plan for what our goals are around quality. What are the metrics that we're prioritizing, that we're measuring our performance by for the health outcomes? You'll see lots of national performance metrics included, like the HEDIS measures, which are national measure sets around healthcare quality and outcomes, member surveys and member experience surveys about their level of access to care, their level of satisfaction with their provider, their satisfaction with their health plan, and also more focus on engaging the health plans and helping us with performance improvement projects. So identifying priorities, areas of concern, areas where we see opportunities to improve, and focusing our efforts around them. Utilization management is another key responsibility. Looking prospectively at pre-certifying or pre-authorizing certain services before they can be administered to make sure that they fit within the clinical guidelines, that they're at the right level of care, and that they meet our medical necessity criteria. Concurrent review, for example, working with the provider for discharge planning when an individual is ready to leave the hospital to help determine what the right timing is, what that next level of care looks like, and making sure that there's follow-up and continuity of services. So are they getting their prescriptions filled? Are they getting connected into home health as necessary? Then the retrospective review, looking at the claims to give resources and insight about what those utilization patterns look like, and maybe help lower the cost and improve their outcomes. Provider network management. One of the big reasons the states have moved towards managed care is that there are a lot of federal regulations that really limit the state's ability to truly manage the program. Health plans are better equipped and actually have better flexibility to do that. One of the ways is around managing the provider network. Being able to have individualized agreements with different providers that build in certain outcome metrics or reimbursement priority criteria. And also making sure that they have policies for continued access whenever providers change, with someone that is there to assist you in transitioning from one provider to the next, potentially if they leave the network or stop providing Medicaid services. And then having provider education. People that can go out to be on the site with the provider, help the provider with billing issues, claim issues, or the latest medical guidelines that are available. So what's happening with Heritage Health? We've had managed care, as I said, for a number of years in Nebraska with physical health and then the separate behavioral health. Medicaid and long-term care has now entered into contracts with 3 health plans, WellCare of Nebraska, Nebraska Total Care or Centene, and United Healthcare Community Plan of Nebraska. Each of these health plans will operate statewide and provide integrated healthcare services, which include physical health, behavioral health, and pharmacy services to enrollees beginning on January 1st of 2017. We're working diligently to make this transition, including readiness, provider education, planning the enrollment period for members to select and enroll in their health plan, and making sure that the provider networks are prepared for the transition. With all the goals of the program that we've identified, improved health outcomes is the #1 goal. We want to focus on seeing better quality and better outcomes for all of our recipients, better integration of services with better coordination across physical, behavioral, and pharmacy services. So having an emphasis on a person-centered approach toward identifying an individual's needs and then wrapping services around them. Care management, more preventative services, more recovery-oriented care, and reducing the rate of cost in avoidable care. Really trying to examine emergency room utilization for non-emergency needs. Hospitalization, rehospitalization that is unnecessary, just having those metrics in place and engaging the plans and providers to help us address those. Then, of course, the improved financial sustainability of the system. As we bring more services, more populations into risk-based managed care, it creates better budget predictability for us and hopefully lowers the cost growth curve to a manageable level so that we can stay at an annual growth rate that allows us to be sustainable. So one of the big changes, as I said, under Heritage Health is the integration of behavioral health services. This is really designed to help us better identify and manage individuals that have concurring behavioral health and physical health needs. In fact, there's a lot of data that suggests that individuals with behavioral health often have unmet physical health needs or chronic conditions, and the cost of treating those chronic conditions for an individual with a serious mental illness can be many times higher. Their compliance rates are poor, they're in and out of the hospital more often, they're in and out of the emergency room more often, and individuals with serious mental illness live on average 25 years less. So we really want to put a lot of focus on making sure that we're identifying those individuals and wrapping the right services around them. And part of that is just by bringing them together under one contract. You then have one entity that's now contractually and financially incentivized and obligated to look across the full spectrum. With the current system today, there's often confusion about who's paying for what. So if an individual shows up at the emergency room, is the primary need physical or is it behavioral? And who's responsible for them? This split in coverage can limit the motivation to make investments in preventative behavioral health and community-based services. So by bringing all of these services together, you create better incentives to make those investments on the front end. We also know that this is a big change for our system, for our providers, for our staff, to go from having one behavioral health contractor that everyone deals with to having 3. So one of the steps we've taken was the creation of the Behavioral Health Integration Advisory Committee, which includes Medicaid along with the Division of Behavioral Health, the plans, various providers, and advocates, all at the table planning and making sure that we're thinking through all the different things we need to make this a smooth transition in 2017. We're also introducing some new populations into managed care through Heritage Health. Currently, some of the groups that are excluded from physical health managed care, meaning they're completely in the fee-for-services system for those needs, are individuals who participate in our home and community-based waiver programs, like the Aged and Disabled Waiver, the Traumatic Brain Injury Waiver, and the waivers for individuals with developmental disabilities. Those waivers provide in-home care services or other community support services for individuals that have those long-term care needs. A lot of these enrollees also have significant physical health and behavioral health needs. So under Heritage Health, they'll be able to benefit from the advantages of care coordination and having a health plan for their physical health, pharmacy, and behavioral health services. In addition, individuals that live in institutional settings like nursing homes or intermediate care facilities for people with developmental disabilities, those institutional level of care clients will also be in Heritage Health. So while all of these individuals are new to managed care, they will still have their benefits coordinated through their Heritage Health plan. Their actual long-term support services, those actual in-home services or residential services, will continue to be authorized and paid as they are today. So the Heritage Health plans initially are only taking over responsibility for their hospital, doctor's office, pharmacy, and community behavioral health services. Some of the key features that you'll see in the contracts is a greater focus on quality, care management, and introducing the concept of social determinants of health into the health plan's responsibility. We have formalized structures to have cross-divisional partnerships for managing the program and working with the health plans. Performance metrics that are specific to our Medicaid members that are identified in the contract and can be updated with the impact of our quality committee, which met for the first time in June and will continue to meet quarterly. A bigger onus on the health plans to help identify those early needs for care management through those health risk assessments. And then making sure that they're not just looking at the healthcare needs or behavioral health needs of the individual, rather that they're utilizing the overall health risk assessment strategy and care management strategy and identifying individuals who have those other social needs. Whether that's food security or housing needs, we can help connect those individuals into other community and state resources that are available to assist them. Common sense as well as strong data suggest that an individual who's chronically homeless and diabetic is going to have a harder time managing their diabetes and is going to spend more time in the emergency room than someone who's not. If you're worried about where you're going to sleep tonight, it's difficult to manage your blood sugar. So really trying to help identify what those needs are and address them so that the individual, their health plan, and their provider can focus on their specific healthcare needs. There are requirements in the contracts for developing and building provider networks that meet geographic time and distance standards based on where the member lives for all the different types of providers, hospitals, specialists, primary care physicians, pharmacies, behavioral health providers, as well as substance abuse disorder and allied health providers. So lots of focus on primary and preventative care, making sure everyone has an assigned primary care physician. One of the ways we want to begin to measure is, can people actually connect with these providers? Are they accepting patients? Are they able to schedule an appointment? So those metrics are all included as well. And then continuing that focus on the health plans, helping providers develop patient-centered medical homes and meeting those criteria. Accountability is a big theme throughout Heritage Health. We have strong contracts at the foundation that clearly set out what our expectations are and what our performance standards are, and then we want to make sure that we have policies and procedures in place that really hold them accountable. So all of their policies and procedures have to be reviewed and approved by us. We have numerous reporting requirements on both operational and outcome performance metrics for everything from their call center performance time, their claim processing timeliness, to those actual outcomes and HEDIS metrics. Plans are required to give us full access to all of their systems and information. We'll be conducting periodic operational and readiness reviews prior and after we go live. And there are also financial incentives, sanctions and penalties built into the contracts and tied to their performance. They have to deposit 1.5% of their total revenues into a reinvestment account that they have to earn by meeting certain quality metrics. There are financial sanctions and intermediate sanctions in place. If they don't meet certain contractual responsibilities, then those quality metrics that are tied to performance standards will be revisited annually with the input of our quality committee. We also want to make sure that we're supporting our providers. Managed care is not always fun for healthcare providers, and admittedly, we're adding additional layers of administrative complexity to the system. Under the traditional fee-for-service model, there's only one entity to bill, which is the state. So health plans do add that additional layer, but those plans are making sure that there's proper concurrent review, utilization management, accurate billing, and ensuring providers are credentialed properly. So while we recognize those challenges, we do think there's value in creating those layers. But we also want to make sure that there aren't layers of administrative complexity that don't add value to the system. So we have contractual requirements, making sure they have timely processing, timely payments, timely credentialing, application processing. So there are standards that are all set there. We are also going to require that they continue to follow our state preferred drug list. Even though they are managing the pharmacy benefit, they will have to follow our PDL. So prescribers won't have to navigate multiple different preferred drug lists to figure out which specific drug they should be prescribing for a member depending on which health plan they have enrolled in. There are a lot of requirements for the plans to engage in provider training and making sure providers are ready to bill in their system and that they understand their policies and procedures. So having dedicated provider support staff available in our state on the ground, ready to assist providers, and that they also individually have provider advisory committees with Nebraska providers to meet regularly and provide input about operational issues and a provider complaint system. We also have an administrative simplification committee that meets regularly with state staff, health plans, and providers to focus specifically on these issues and continuously identify opportunities where maybe we can create some consistent policies across health plans, consistent health forms, or other areas where we can knock out any administrative complexity that's not adding value. So speaking of value, we really wanted to focus on value within these contracts. One of the ways that we're trying to tackle that is that the health plans are required at certain points in their contracts to have certain percentages of their provider networks in value-based contracts. And what that means is in their contracts with the provider to provide services for the members, they have to have some element of quality outcome or cost metrics that they are then engaged with the health plan in meeting. And then there are also financial incentives to meet those, whether that's performance payment, shared savings methodology, or subcapitation, which is when they actually pay the providers a fixed monthly rate, managing their patient populations while taking on some of that risk as well. There's multiple different ways that plans and providers can enter into these types of arrangements, but we didn't want to be terribly prescriptive because we want the plans and providers to determine what works best for them and what works for their type of practice. So for example, you might begin with an upside-only shared savings where the provider only gains if they save money but doesn't necessarily lose if they don't, and then evolve over time to true shared savings and loss where they take on some risk. There are several ways they can tackle that, but we wanted providers to be engaged and have the same incentives as the health plans to manage care, create better outcomes, and to lower the cost. So under the current system, you've got this constant tension between the payer and the provider where one makes money while the other one loses money. So we want to try and ease and reduce some of that tension that exists. A big focus, obviously, for us is on our members. They're at the heart of what the program is all about, and it wouldn't exist without them. So we've got to make sure that there are strong protections in place for actually engaging them in the program. Making sure that the health plans are providing them with timely and accurate information, that it's accessible, it's at the right level with the correct information in it, that they have a toll-free call center, that they're meeting those performance standards, that their grievance process is extensive, it's approved by us, ensuring they will always have access to the state fair hearing process as a step beyond those initial MCO appeals, and that they do member surveys using national standards. The CAP survey, which is a National Health Plan recognized survey process, which can measure objectively kind of what the member experience looks like by health plan, and then member choice. We want to make sure that members are engaged in choosing their health plans now, and that during the open enrollment period, if they're not satisfied, they can choose a different health plan. So one of the ways we're doing that is by expanding our enrollment broker capabilities. Our enrollment broker will be assisting the members with their choice to find the plan that best fits their needs. We want the members to select their plan to have that voice in their care. And when absolutely necessary, if the member is unable to choose a plan, then the enrollment broker will have the responsibility of auto-assigning members to the plan that meets their individual needs. We want to support our partners across the division and other state programs as well. There are clear requirements that the Heritage Health Plans have liaisons and coordinate with sister DHHS divisions to have them participate in our committees. Behavioral health and developmental disabilities, children and family services will be involved for the youth that are in foster care, as those youths that are in the system will be receiving services through Heritage Health. Bringing various representatives together will give us better alignment and coordination. This expands beyond DHHS as well. There's the Department of Education, Office of Probation, other community and local agencies. We want to bring everyone to the table and have expectations that the health plans are communicating and coordinating with. And then, like I said, we want to make sure we have a smooth transition. The plans will have to submit to us for approval their transition and implementation plans. We're currently immersed in our collaborative implementation period. There are key staffing requirements that are in place throughout this period, specifying which roles need to be filled to ensure a presence throughout the time frame leading up to 2017. Additionally, they have to have their network in place 3 months before we go live to make sure that we'll be able to assess if they're meeting our network requirements and that their members are prepared to transition to those providers by January 1st of 2017. There are also continuity of care provisions that require that any services that have been pre-authorized for a certain period of time after the contract starts will have to be authorized, even if it's out of network, for a certain period after we go live. I briefly mentioned our enrollment broker. We've contracted with automated health systems to provide this service. A key principle for Heritage Health is member choice. So AHS will provide member outreach and support during the open enrollment period to help individuals determine which health plan best meets their needs. Their contact includes letters alerting the members of the open enrollment period, phone calls to provide any necessary counseling as they review their options, and searchable databases for primary care providers. We want to make sure that we have regular communication about what's happening and what's going on, so we've created the Heritage Health branding to help create a unified picture of what the program looks like. We've launched web pages where you can go and learn more about Heritage Health. There are links to the procurement materials, the RFP, and the contracts. Our presentation materials and handouts are all posted there, including this PowerPoint. We've also posted an FAQ that's being continually updated throughout the process, and we have a link where additional questions can be submitted to our subject matter experts. The clock is ticking down to 2017, and we have a lot of information to broadcast about Heritage Health. So we're taking those proactive steps in communications to ensure that we have significant stakeholder involvement as we move forward. So where are we today? This is a broad overview of what the timeline currently looks like. As I mentioned before, we're in the midst of the implementation process. Our committees for quality management, behavioral health integration, and administrative simplification are now in full swing. These committee meetings are part of the Nebraska Public Meeting Calendar with agendas and meeting materials provided on our website. We're looking ahead to our readiness reviews, actively planning the open enrollment approach with AHS, and keeping our sights set on that go-live date of January 1, 2017. Again, I just want to emphasize that our focus is on unity. We know that we're better together, so each of the divisions within the department are present at the table. We're all collaborating to work together on this. Even though it's a Medicaid program and Medicaid contracts, the entire agency touches base with these same clients across different programs. At the heart of it, we're all trying to work together to deliver better services for the people and deliver better value for the taxpayers. So we want to make sure that we have good communication as we move forward with Heritage Health. The web page for Heritage Health is being updated regularly, and any questions about Heritage Health can be submitted through the link on that page or by email to dhhs.heritagehealth@nebraska.gov. And Nebraska is spelled out in our email address. So I'd like to thank you all for your time today and encourage you to subscribe to that web page for updates and to email our office with any questions that you have. So at this time, we'll welcome Nebraska Total Care to share information with you as it relates to their plan.
Thank you. This is Phil DeVecas. I'm an account executive with Nebraska Total Care on the pharmacy side. So glad to be here today. Thanks for all that great information. Nebraska Total Care is a Heritage Health NCO effective January 1, 2017. Today I'm just going to go over a high-level overview of our program. Nebraska Total Care, we are a new plan, as I said, effective 1/1/17. Nebraska Total Care is a Centene Corporation health plan. NTC will be located in Omaha, Nebraska. I'm trying to work my screens here. I'm froze. Is there an administrator that can help me advance my screen?
There you go, Phil. It advanced on the next one.
Okay, thank you. We're Centene Corporation. Nebraska Total Care is a subsidiary of Centene. Centene is based in St. Louis, Missouri. We were formed and founded in Milwaukee in 1984. We're currently 124th on the Fortune 500 company. In 2015, we're pleased that Fortune ranked us as the 4th fastest growing company in the United States. We currently have over 28,000 employees. What we do, we're a managed care organization in 28 states. We have 24 states that we provide Medicaid services. 15 states we provide exchange services. 12 states we provide Medicare special needs programs. And we support the correctional systems in 8 states. We are also in 2 international markets. We currently serve over 11 million members through 290 products throughout the country. This is just a broader picture of where we are. You can see that we're headquartered in St. Louis, and you can see the golden states are the states that we currently do operations or will have operations in on January 1st. U.S. Script is the PBM currently. We are a Centene-owned PBM. We are rebranding right now, so you're going to see some new names. U.S. Script will be known as Involve Pharmacy Solutions. The same as U.S. Script, just rebranding to Involve Pharmacy Solutions. Involve Pharmacy Solutions provides Medicaid customers in over 23 states, and it's over 8 million members. Through the Involve family, we're going to provide the eligibility enrollment, claims adjudication, encounters, management services, and network management. Through the Centene Involve organization, we provide integrated specialty health solutions. There's 3 main branches to the Involve under Centene. We have the Involve Pharmacy Solutions, which is the PBM, and also the Area Health Specialty Organization. Involve People Care provides the mental health and other services, 24-hour services, et cetera. And the benefit options for vision and dental are provided through Involve Benefit Options. Somebody advance that for me. So Involve Pharmacy Solutions supports Nebraska Total Care. We are the PBM supporting Heritage Health Plan. Our goal is to ensure that we have a high-quality, cost, and effective pharmacy benefit provided through Nebraska Total Care. Design the clinical programs that meet the needs for the state of Nebraska and the Heritage Health Program. Treat your patients as you would with compassion and care. And we do value your input for the care that we provide to our members. Need somebody to help me advance. Thank you. A little bit on Nebraska Total Care. As mentioned before, we are following the state preferred drug list, the PDL, with all the edits, quantity, pH, step edits, et cetera. Nebraska Total Care will wrap the PDL with a formulary for therapeutic classes not under the PDL, which would be the formulary. Nebraska Total Care will provide the edits for the Nebraska Medicaid Psychotropic Drugs and Youth Initiative. And the PBM, again, just to be clarity, is the PBM is Involve Pharmacy Solutions. And then you will see the Caremark CVS name. They are handling our network services. The CVS contracts with the pharmacies for the retail benefits. So many of you may have seen an addendum that's been mailed to you. So there's a separate addendum required for the state regulations to participate in the Medicaid program in Nebraska. The rates are negotiated between CVS and the pharmacies through the independents directly, the PSAOs and chains. The state set a minimum dispensing fee for all the independent pharmacies. There's no transaction fees for the state contract. And the contract requests for the addendums were sent out on 6/30/16. So for specialty, we're preparing a separate specialty contract with Involve Pharmacy Solutions. We are working with the state to finalize that agreement, and that should be out soon. So if you're interested in specialty participation, watch for these agreements in the mail soon. Effective January 17th, the NTC Involved Pharmacy Solution claims will be processed utilizing the VIN number PCN and RX group that you see on your screen, the VIN 004336, the PCN MKADD, and the RX group number will be a full RX 5459, and this information will also be printed on the member's ID cards. Nebraska Total Care will have a medication therapy management program that we're developing. We will be engaging the local providers, local pharmacy providers in the MTM program, so there'll be more information to come on our MTM program. For the initial group of members on January 1/17, there will be a 90-day transition period to allow members to continue on their current therapies. We're going to be receiving PA files and loading those PA files into the system to ensure that we have a continuity of care. Who to contact? Contracting and payment for retail, again, is through CVS Caremark. There's your phone number and your fax number if you need to discuss or if you need additional information regarding your pharmacy contract. Contracting and payment for specialty is going to be through Involved Pharmacy Solutions, the PBM. We have an email address here. However, we are still working on those contracts and we'll be getting those out to you shortly. Prior authorization requests will be Involved Pharmacy Solutions, and we have our phone number and fax. And I believe that's all that we had to share with the team today. I believe we're going to hold off Q&A until after the third MCO presentation. Is that correct?
Yes, that's correct.
Excellent. Thank you so much.
And next up, we have United Healthcare Community Plan of Nebraska.
Thank you. I'm Dr. Michael Horn. I'm Chief Medical Officer for United Healthcare Community Plan of Nebraska. Just want to take you through a few slides to introduce ourselves to those of you who don't already know us. And then I'll be joined by other partners, Jasmine, Jim, Jean. So let's go to the third slide. Oh, there we go. Just some facts about us as a health plan. United Healthcare has been in Nebraska since 1984. Between our commercial plans, our Medicaid plan, Medicare Advantage, and TRICARE, we serve more than 428,000 individuals in the state with over 328 employees located here in Nebraska. And nationally, we have over 200,000 employees engaged in our operations. For the Medicaid plan in particular, our community plan, we've been operating in the state of Nebraska for 20 years, and we've been NCQA accredited since 2005. So many of you will have already encountered us and know us. Next slide.
Hello.
We're going to enhance and expand our whole person model of care with the January 1st contract. So in this schematic, the member's primary care provider is still front and center. We still have community health workers and a behavioral health advocate as part of that current team. But over time, we will be adding pharmacy and additional peer support members, a resiliency and recovery specialist. And as alluded to earlier, you kind of see that Child and Family Services and the Division of Public Health, Division of Behavioral Health, Juvenile Court and Probation are partners that we will in the future work with more closely to integrate the care provided to our members. Next slide, please. We like to share this so people understand what drives and informs our decisions. So integrity, we look to honor our commitments and not compromise our ethics ever. Compassion, where we walk in the shoes of the people we serve and with whom we work. Relationships, we like collaborative relationships and build trust over time. innovation for the future, and of course demonstrate excellence in all that we do. And with that, I'm going to hand off to Jasmine Crenshaw.
Awesome. Thank you, Dr. Horn. So hello and welcome, everyone. Optum RS is very eager to engage our pharmacy community within the state of Nebraska. I'm just going to cover a couple of slides with you today. One of the things that we want to just kind of go over is just kind of the contracting strategy for this particular market. And so pharmacy contracts were sent to our United Healthcare providers within the month of May. One of the things we kind of talk about, and to go back to Dr. Horn's point, is he talked a little bit about innovation. So one of the things that we've tried to do is create efforts of efficiency. And so in order to kind of streamline our contracting process, one of the things that we've done is we've implemented an online process for contracting, and they manage the full life cycle. So some providers may have the option to have a contract mailed to them, but we also do have the flexibility to email the contract directly to the provider and have them actually review the contract, complete their credentialing application all online, and have it executed back to us in real time to kind of speed up the process there. So that's just one of the perks, I think, you know, we always look to kind of create, you know, streamline and create efficiencies and kind of evolve our process. One of the other things I'd like to also point out on our slide here today is that we have updates regarding our reimbursement. And so we have what you would consider MAC pricing, which is updated weekly. And we also have our MAC appeal process. So any provider that has or experience issues as it relates to MAC, there's a defined appeals process. That defined appeals process is available online at on our provider portal. The link to that is http://learn.optumrx.com. And page 23 of that document actually defines our pricing appeals process. It's a pretty easy process. I won't spend too much time going through it, but basically we ask that the provider give us some very key information so that we can kind of solve for the issue. So we ask for the VIN, the PCN, the group, the pharmacy name, the NCPDP, the RX number, the field dates, and then we ask for the NDC. Once we get that information, then we take that information and look at the amount that the provider is disputing, and then we provide a response within a week's time. So the turnaround time is typically a week to have those type of issues resolved. In addition to that, one of the things we also like to talk about is that we do have an immunization program. And so when we talk about the covered immunizations covered by the program, we do cover the immunizations in addition to the administration costs. And then we also have what you would consider a dedicated customer service line. And so when people say customer service, they all start freaking out because they're thinking you're getting member service, but we have a dedicated provider line, and we are here just to work with our provider community to address any type of issues, concerns that they may have. And we try to make sure that we are, you know, kind of able to assist you in every step of the way, because we want to make sure that you have a excellent experience with Optum RX. And so we can be emailed at www. It's provider.relations@optum.com. And then we have our dedicated provider relations line, and that phone number is 877-34701. And that information will also be on our next slide that we're going to advance to now. Perfect. And so one of the things we also want to take a little time kind of going through with is that if you're experiencing any type of issues, we're available for you. Always feel free to reach out to us via phone or email. We respond to our email box daily. So if you haven't gotten a response, need another response, feel free to reach out to us. I'm actually having a dedicated person, an extra dedicated person man the box just for our wonderful pharmacy community for the state of Nebraska. We look forward to engaging with the provider community. In addition, just want to call out some key information as it relates to DME. So United Healthcare will continue to cover diabetic testing supplies and limited home health supplies via the pharmacy benefits. Comprehensive DE is covered through the medical benefit, and all providers interested in contracting with or have DME questions can contact United Healthcare 866-331-2243 or email the Nebraska contracting team at nebraska_team@uhc.com. For more information regarding the contracting process, you can also visit the website at www.unitedhealthcareonline.com. Thank you for your time today. And I am going to, I apologize. Wow, I can't believe I missed that one. So one of the things I kind of talked to when we initially kind of started, we talked a little bit about the contracting process and that we have a automated electronic process that's pretty robust. Within that life cycle of that contracting process and that credentialing packet that was mailed also includes the credentialing application. And so when you think about the credentialing application, it's for us to make sure that we're contracting with quality, sound providers. And so it's also, so the credentialing application is included within the contracting packet that was sent out in May. Some pharmacies, if they requested it via mail, would have received it via mail, and some pharmacies would have received it via echo sign. In addition to that, within the packet, it looks at items such as providing your federal tax ID number, making sure that you have appropriate professional liability insurance, understanding who the pharmacy is owned by and if you have any affiliations, accreditations. We also take a look at if you have current state license, including DEA number. And so this is kind of typical of your standard credentialing process. And we credential providers at onset, and then we re-credential every 3 years. And we can advance to the next slide. So typically when we talk about the contracting life cycle, the contracting process typically takes about 7 days. So, and that's using kind of our electronic standard process. Using that electronic standard process, we have 2 streams. We have independent pharmacies, and those are the pharmacies that contract directly with Optum RS, and they go through our life cycle of contracting and credentialing. That process takes about 7 days. However, we have a separate path to credentialing. So if a pharmacy is affiliated with a PSAO or a chain, that chain or PSAO has been delegated to perform credentialing. And so they make sure that that pharmacy that's affiliated with them has appropriate DEA number, has their license that they need to have in the state, and they verify all of the standards that we hold our independent providers to as well. So there's 2 happy paths when it comes to credentialing. Independent pharmacies work directly with us. PSAO and chains work directly with their pharmacy locations and credential them directly, and then Optum provides oversight to those chains and PSAOs to make sure that they have policies and procedures that's in place that meet our standard credentialing requirements, and we perform audits on those PSAOs and chains as well. So if you have any questions as it relates to pharmacy credentialing, please feel free to contact us at area code 877-633-4701, option 2. And then you can also feel free to email us at pharmacycredentialing@optum.com. Thank you so much for your time today, and I'm going to pass it over to Jean.
Thanks, Jasmine. This is actually Jim. It's Jim Hankowski. Thank you, everybody. Thanks, Jasmine. Thank you, Dr. Horn. So I'll keep going and wrap this up. So pharmacy claims processing information. So as you heard before, Optum RX is the PBM, the BIN 610494, or the PCN number, and the specific group ACU and E. This will also be on the card, and prior to go live, at least once, if not twice, we'll distribute a communication to the pharmacy network, reiterating again how to adjudicate a claim with the BIN, PCN, and group number at Optum RX, and then additional details about the program. Nebraska Medicaid will define the PDL, and UHC will be waiving any copays for our program in Nebraska related to pharmacy services. If you walk to the next slide, we'll talk a little bit about the PDL and prior auth. Just reiterating as we did here, we will be following the Heritage Health's defined PDL. That will provide consistency across all of the programs. There are prior authorization on certain medications. United's real focus is on empowering the pharmacist with information at the point of sale. So we're going to spend a lot of time to make sure we're providing good information if a claim does reject based on management. And that could be making sure that we're messaging the alternatives that are on the state's PDL, or details related to the quantity limit, or if the drug requires prior authorization. Ultimately, to give you the tools to hopefully be able to resolve that issue for the member that's standing there in front of you. If a prior authorization ultimately is required, prescribers can submit through a prior authorization process. We're calling in or faxing in. And just in general, UHC Community Plan has a link for all plan information, but there's a sublink under there related to pharmacy services. Specialty pharmacy program. We will have a specialty pharmacy program for the Nebraska. We think it's important to make sure we're able to wrap quality and specialized patient care clinical support services around these very critical medications. We all know some products are only available through a limited distribution network, so that necessitates a need for a specialty pharmacy program. The key I want to point out is the last bullet. It is an open network, so all providers, we are willing and open to participation in the network, with the terms we will specify. Again, the program, as you heard before, needs to be approved by the state of Nebraska, and once that's finalized, the contracting documentation will be available. MTM's the next slide. MTM's real important. As you heard at the beginning from the intro from Dr. Horn, whole person care model is essential to how we're going to deliver care, and pharmacy is part of that. And retail pharmacies are a key part of that also. We've heard the statistics, pharmacists probably see the patient member more than any other provider out there. So the MTM program will deploy retail pharmacists are a key component to that program. And the way I think of it, it's more than just a CMR whenever we're thinking comprehensive medication review, from the Medicare experience. I think we need a little more collaboration, particularly for our fragile Medicaid population, and we're looking for gap facilitation. And ultimately, if we do MTM right, I really believe it's going to be clinically appropriate and very cost-effective care, which is a win-win for everybody. And then in general pharmacy communications, the next two slides are really the next three slides are really the resources we have available. So communication, Jasmine talked about it through the pharmacy manual, a lot of details there on PBM processes and documentation. We'll use fax blast through Optum RX as a key method of communicating changes to the program. There's a web-based resources, and then town halls such as this for talking with the network. The resources I talked about on uhccommunityplan.com, and some details on the additional information that is available related to the pharmacy program. And then the final slide is contacts. Just putting it all in one place for you. The pharmacy help desk at Optum RX 24/7, 365, credentialing and contracting contact points, MAC and pricing questions, and then in general, our in-market person is Jean Kavanaugh And there's our direct information if you have any questions concerning our pharmacy program. So thank you.
Thank you, Jim. Now we'll move on to WellCare of Nebraska.
Good afternoon. My name is Lee Genko. I'm Vice President of Pharmacy Benefit Relations. I'm here with Bill Davies. He's our Vice President of State and Specialty Pharmacy Programs. So WellCare of Nebraska, we have 3.5 million lives nationwide. We have a presence in 9 states. We are excited about the opportunity to participate in the Heritage Health Program. We currently operate in the state with our Medicare prescription drug plan, so we are, again, excited to go live on January 1, 2017. We contract with CVS Caremark for our PBM services. CVS is responsible for managing the pharmacy network along with credentialing, pharmacy fraud, waste, and abuse, as well as pharmacy help desk support. WellCare is responsible for managing the PBM relationship and maintaining oversight. Next slide, please. So CVS is responsible for the contracting, and the state addendum, a separate addendum, is required. So we would encourage you to sign and return that addendum to CVS Caremark. Independent pharmacies are being contracted and solicited with a $4.45 dispensing fee. Chain pharmacies are identified by those as having more than 6 pharmacies are being contracted at the national reimbursement rates. There are no transaction fees or click fees according to the contract. The solicitations from CVS went out to the network on July 8th. If an agreement has not been received, we would encourage you to contact CVS at 866-488-4708. And then if you're not sure who to contact about a network agreement, as a chain pharmacy, would encourage you to reach out to your chain headquarters. Independent pharmacies that are enrolled through a PSAO, or Pharmacy Services Administrative Organization, would encourage you to contact your PSAO. And independent pharmacies can contact CVS's Network Services team, again at the same number, 866-488-4708. Claims routing information through CVS, BIN number is 004336. PCN is M as in Mary, CAID, V as in Victor. The RX group number is RX8896. And payer sheet information is available at www.caremark.com/pharminfo. And I'm going to turn it over to Bill Davies. He's going to walk through some of the additional slides.
Thank you, Lee. Hi, I'm Bill Davies. I'm here to talk about the additional slides. WellCare does use our own homegrown proprietary prior authorization process. We will turn the prior auths around in 24 hours. We do use a decision tool where a technician can approve but cannot deny. Any denials will go to a pharmacist who can approve or deny. If it's medical necessity, it'll then go to a physician who would have to deny. We are going to be using the PDL from the state. We do have experience in that area. In Florida, we do the exact same thing. So we do have experience working with the state's PDL and criteria. Next slide, please. Thank you. WellCare does have their own specialty pharmacy. We call it Exactus. We do work with CVS Caremark, where there are some drugs that we can't get at Exactus that are limited distribution. If they can't get it, then we will work to find out which pharmacy does have the limited distribution drug to make sure the patient does get the drug. And due to version control, there should be another line item on here that says any specialty pharmacy meeting the terms and conditions, including accrediting and clinical programs, will be considered for contracting. So if you have a specialty pharmacy and you're interested in dispensing medications to our patients, please contact CVS about getting in our specialty network. Next slide, please. Medication Therapy Management Program is called the Healthy Living Program. We have built a program along with CVS to look for patients who might be at a higher risk, to make sure that we put them in the program. Some of the programs include psychotropic medication program, a core safety and monitoring program, a medication adherence program, a gaps in care program, a polypharmacy program, an ADHD program, and a medication reconciliation program. So we will be working with the members of Nebraska to make sure that they get the best possible care possible. Next slide, please. And two additional items, we do allow DME to go through the pharmacy, things like blood glucose accessories and things like that. And currently, WellCare does provide mail order, but we prefer that you use the retail pharmacy network. If somebody's out in the middle of nowhere, we do allow them to use mail order, but we don't market it, and we prefer that they use the retail network that's available. Thank you very much. We'll now open it up to the next stage.
Our next portion is our Q&A, and we have had a couple of questions come across on our Q&A box. The first question, I believe, has been answered already by each of the health plans slides. So there was a question about have the BINs and the PCNs been assigned by the MCOs yet? So this presentation will be posted to our website. We have a dedicated page to the Heritage Health Managed Care Program, and within that is a resources page, which is where we will have our presentations located. So you'll be able to find the BIN and PCN numbers for each of our health plans in their presentations. There is a question about a clarification on Medicaid patients being in an MCO for prescriptions and claims for DME. So as Carmen explained, the majority of our Medicaid clients who today will be enrolled in Heritage Health for January 1. So clients who have historically been excluded from managed care participation, those who are receiving long-term services and supports, either through home and community-based waivers or living in institutions, or those who have Medicare as their primary, have historically been carved out of our managed care delivery system, and they will become mandatory to enroll in for January 1, which means that they will have their physical health services, which does include durable medical equipment, so DME is considered a physical health service. Their behavioral health services and their pharmacy services will be covered by the managed care plan in which they enroll. I also want to emphasize that that also does include pharmacy or the drugs for people who are living in long-term care facilities. So if there are some long-term care pharmacies that are dialed into our webinar, wanted to make sure that you are aware that once January comes, the managed care plan will be covering the drug or the prescriptions for clients living in nursing facilities and the intermediate care facilities for those with developmental disabilities. There is a question about copays. Copays are imposed in our legacy fee-for-service program, and it is up to each of the managed care plans to decide whether or not they will continue with the copay requirements or if they will be offering no copays as a value-added service. So I would refer you to each of, I would encourage you to contact each of the health plans individually to find out whether or not copays will be included or will be imposed with their health plan. The next question is a question about currently being enrolled with United Healthcare, Optum RX, Caremark, and CVS, and is there a need to re-enroll for the Medicaid managed care? The answer is yes. Each of the health plans do have a Nebraska Medicaid specific addendum that they will be asking you to complete and send in. And if you have not received that yet from any of the health plans, all of their contact information are available on the slides, which will be on our website. The next question has to do with over-the-counter medications? Will over-the-counter medications continue to be covered? And the answer to that is yes. The over-the-counter medications that are covered today, the MCO must, at a minimum, cover the those over-the-counter drugs. The next question is asking if there will be a web-based claims portal or if it will continue to be available. We do not have point-of-sale capabilities for this particular provider. Oh, and this a critical access. So I guess I will ask each of the managed care plans to address their online portal capabilities for billing and for critical access hospitals specifically. So Nebraska Total Care, I'll let you go ahead and respond first.
Great. If I understand the question is portal access, yes, there will be portal access, and we also utilize CoverMyMeds for PA submission, and there'll be access through both the PBM and the Nebraska Total Care website.
United Healthcare?
Hello, this is Jasmine. And so in response to that question, yes, providers will have the availability to go on to Optum's provider portal. And on that provider portal, they can verify eligibility. They can run a test claim. They can check claim status. They can download an 835. And then they can also look up member touch measures. So absolutely, we encourage it.
And then WellCare.
We have the same capabilities through CVS Caremark on the provider web portal.
Yeah, so all of the health plans will have web portals for submitting claims, either through their point-of-sale vendor for their prescriptions or through their physical health side of the shop for medical claims and other type of claims. So the next question is, currently drugs for home infusion go through the state using the NCPDP format. How will this be handled with the Heritage Health plans? Should this be sent as a medical claim or a pharmacy NCPDP claim? So again, I'm going to refer that out to the health plans to address that question, and we'll start with Nebraska Total Care.
I will get a communication out to the team on this on the home infusion. I just need to get a point of clarification, and I want to make sure I give you the right information. So we'll get a note out.
Okay, thank you. United Healthcare?
This is Jasmine.
Okay, Jasmine.
I was just going to say that Optum RS has a robust home infusion network to be able to support our Heritage members.
And WellCare.
This is Bill Davies from WellCare. We allow either NCPDP or through the medical claims. We do prefer that you do it through the NCPDP route.
The next question is, will nursing facility and assisted living facility residents continue to be exempted from any pharmacy copays? And that will continue. The Nebraska Medicaid program defines the extent of the copays, who the copays apply to, and what services those copays apply to. So even under the Heritage Health program, the recipients and the services that are exempt from copay today will continue to be exempt from copay in the future. The next question has to do with dual eligibles. Will dual eligible residents utilize benchmark plans for their Medicare Part D, or will each MCO utilize a specific Part D plan? I believe that it's really not up to the MCOs to utilize the Part D plan, that the clients are the ones that choose their Part D plan. The next question is a clarification for the critical access hospitals. And I just want to assure the critical access hospitals that each of the health plans have an online portal for submitting claims. The next question is, will medications for nursing and assisted living residents be provided in unit dose packaging? And I believe the answer to that is yes. I guess I will check with, or I will just let you know that I believe that it's either in our regulations or going to be in our regulations, but I do believe that that is addressed in the fact that for nursing facility and assisted livings, those will continue to be unit dose. This question appears to be to WellCare. So the question is, my understanding is that specialty will be any willing provider. It sounds like especially WellCare will be keeping in-house and using CRK. I will let WellCare address that question.
Yeah, it's any willing provider. We have an in-house specialty pharmacy, and we do use CVS if we can't provide it, but it's any willing provider.
And that is a requirement of our contract, that if the provider agrees to the terms of the contract with each of the Heritage Health plans, that it is any willing provider.
Correct, and I tried to read that. It fell off the slides, but I tried to read that.
The next question is for United Healthcare, specifically for home infusion. The question is home infusion billed through the plan or through the NCPDP or through the major medical, or both?
Yeah, this is Jim Hand. So this is Jim. Yeah, that didn't get clarified, so I will clarify. Home infusion should be billed through, I guess it's called the medical, using the standard NCPDP transaction standard, not through Optum RS.
Jim, could you clarify that, or at least get a follow-up and provide clarity, because NCPDP usually does not go through on the major medical side. NCPDP is usually only on the pharmacy point-of-sale side.
Right. I will. Well, we have that as a takeaway. We'll clarify.
Thank you. The next question is asking about an ETA on specialty pharmacy criteria. So the question is, what aspects of the terms and networks will Heritage Health drive out to the MCOs and the PBMs? There are contract requirements in our contract around specialty pharmacy, and the fact that they must contract with any willing provider for the drugs that Nebraska Medicaid defines as specialty drugs.
That's the instructions I gave.
And I'm going to check to see with the pharmacy staff at Nebraska Medicaid to see if they wanted to add anything else to that response regarding specialty pharmacy criteria.
This is Shelley with the state, and in reference to specialty pharmacy, we will be reviewing each of the health plans' specialty pharmacy list. We do not have a list of our own, but we will be approving that first.
Thanks, Shelley. The next question is a follow-up to the critical access hospital question. regarding the will additional software need to be purchased to process claims, and I would refer you to each of the Heritage Health plans to ask them that question, and I would ask that you refer maybe offline from this webinar, if you could reach out to the health plans to ask your specific question. I believe you would be able to get answers to that question. We have no more questions in our Q&A, so we will go ahead and we'll keep talking and see if any more of them pop up, but we have had one more pop up. Are all the states going to use the set state dispensing fee for reimbursement? So the contract with each of our Heritage Health plans that is with the state and with Medicaid specifically requires that the managed care plans reimburse the independent pharmacies the state set dispensing fee. The non-independent or chain pharmacies dispensing fee would be negotiated between each of the health plans and the pharmacy. The next question is regarding test pharmacy transactions. Will we be able to complete test pharmacy transactions prior to 1/1/17 to ensure that there are no issues prior to go live? I will let each of the health plans address that question and start with Centene.
We will be working with the state and doing testing with the state. If there's specific questions on a specific test, if you could submit that to the state, we'd be happy to work with the pharmacy.
United Healthcare?
This is Jasmine, and so in response to that, we will take this as a takeaway and reply back out to, put a communication back out to the team regarding implementation and the availability to run test claims.
And this is
Thank you, Jasmine.
Go ahead. Lee with WellCare. I would encourage you to reach out to CVS Caremark if there's questions about submitting pharmacy claim transactions during tests.
The very last question is, we haven't gotten our contracts yet, and so who would we contact? So we again will refer you to each of the health plans' presentations on who to contact. Also, each of the health plans does have a common phone number, there we go, if I could just get it out, and or a email box with each of their presentations that you can send that information to, and they will let you know if your provider base has gotten their contract and who it may have gone to if you haven't seen it yet within your facility. Okay, I believe we've been able to address all the questions that have come into the Q&A box. As a reminder, this presentation, including the recording in each of the health plans, specific PowerPoint presentations will be on the Heritage Health website. You also can subscribe to that page and enter your email address, and you receive notifications whenever that page is updated. So if you are already subscribed to our page, you will receive an email notifying you when the presentation materials have been posted to our website. So thank you for joining us today for our Heritage Health Provider webinar with a focus on the pharmacy provider. Thank you very much. Have a great day.